A very good afternoon and a warm welcome to everyone. And at the outset, before I begin, I'm going to have to congratulate the organizers and also thank them for the opportunity. So we've had 6 interesting abstracts being being just presented now, and I'm going to take you through that through the course of this panel discussion. And I'm pleased to have such a star-studded panel here to take me through the course of the discussion. So I think this is what it is. We're going to be here for a good time, hopefully not for a long time. So I'll request all my panelists to keep it short and sweet. So I think this is the landscape of EGFR mutational epidemiology that we know. We know we have sensitive mutations and resistant mutations as well, starting from exon 18 to 21, and we know 20 exon 20 insertions and the gate Krupa mutation T790M, not very sensitive mutations to EGFR TKIs. So let's keep that in mind before we go on. So my first question, do you believe that in practice all the EGFR mutations, especially the most common ones being exon 19 deletion and exon 21 L8FR, should they be treated along the same lines, or would you want to treat them differently? I'll probably begin with Akhil. At least, yes or no should be fine. Do you believe they should be treated differently? Or let's get to how differently a little bit later on, but yes or no?
It's better to treat them differently if feasible.
Okay, fair enough. The others?
Surely, if the drugs are non-toxic, they have to be treated differently. But considering the toxicities of the different drugs available.
Okay, but you believe that they should be treated differently. Okay. Dr. Vanitha, ma'am. Yeah.
I don't know. As of now, we are treating it the same only.
Okay, as of now. Okay, fine, fair enough. But I think we all know that, Yep. Dr. Pratik. So do you believe that they should be treated differently, even the most common EGFR mutations? Because we know that one is a substitution mutation, the other one is a deletion. So considering that we've had different outcomes, even with the EGFR TKs for both these exons, do you believe that there's a rationale to treating them differently?
Well, from my background of basic biology, yes, all the EGFR mutations that we are talking about, they are more contributing to TKI sensitivity. But from clinical perspective, I see some heterogeneity is there, but it's still not that great that you prefer any other option over the TKI.
Okay, you're still saying we are not there yet. Okay, fine. Probably I'll hope I can change your mind as we move along. So I think we are actually doing that, because if you look at all the uncommon mutations, I know most of us would prefer using afatinib in that setting, because the data for afatinib in the uncommon mutations is pretty good enough. And as far as osimertinib is concerned, we all know about the CNS efficacy. So let's get into the NEG-0206 data, which is a Japanese study, and this was the updated PFS analysis showing that there was a huge PFS benefit of close to absolute improvement of close to 7 months. The final overall survival, however, did not show any difference whatsoever. But this is probably where it gets interesting, because you can see that the same magnitude of benefit in both the exon 19 and the exon 21 L8FR. So, Vanitha ma'am, I'll probably ask you, where would you place this combo in your practice? Or do you believe there's no role for a EGFR TKI plus VEGF inhibitor?
There is, but maybe not bevacizumab. So I don't think that, I'm not pushed to give bevacizumab.
No, fair enough. Even ramucirumab with erlotinib also, another. But where would you like to place it, in your armamentarium?
So maybe not in the first line. So in the first line, if I were to choose combination, I would add chemotherapy. So maybe at progression, if I were giving an oral TKI, I would maybe add ramucirumab or something.
Okay. So any takers for this in the first line, probably in exon 21 L8FR right up front, would you want to use this?
Though there is data to utilize the same, but we are not very convinced with it, and we can utilize it with chemotherapy later on. That is also an option. That is why.
So no takers in the panel for first line anti-VEGF therapy?
Depending on the patient's condition, that's the only scenario when he's not fit for chemo. We want to just give him erlotinib. In that case, adding ramucirumab or bevacizumab is less toxic than adding others.
Probably it's also than giving them only EGFR TKIs. Is that right? Vijay, we'll get your thoughts as well. Vijay? I know we were supposed to do this debate as well, exon 19 versus 21. Unfortunately, you were on, that was on virtual mode. But Vijay, we'll get your thoughts.
So at present, we would treat with F10 plus chemotherapy.
Okay, so you want to do that. Okay, fine. We'll get a little bit later on as well. So this is all the data that we have. It's just not just one trial alone. We have a lot of host of trials looking at adding bevacizumab or any other VEGF inhibitor as well in the form of ramucirumab. And all of them have shown a PFS benefit, none an overall survival benefit show. So I think these are probably one of the reasons as to why L8FR doesn't do well. We have a higher incidence of co-mutations like P53 and RB gene mutations along with an L8FR mutation. So that's just a theory, but has that actually, remember this is only an exploratory subgroup analysis, this was not a pre-specified subgroup analysis. but nevertheless did show that even in the presence of a p53 and an exon 21 L858R, the combination seemed to have the same magnitude of benefit. So I'll throw it back again to the panelists, starting with Akhil. Akhil, what do you make of this data, albeit only pre-specified subgroup analysis?
I agree that patients who are having EGFR exon 21 deletion, they have high chances of having co-mutation with p53.
Perfect.
And we have utilized a combination of ramucirumab with erlotinib in this situation.
Okay.
But the main point is that how comfortable is the patient, because every time, every 2 weeks, calling the patient in the hospital, giving injection when there is a TKI treatment, that is a problem.
But you're saying that probably if your patient is okay with coming once in 2 weeks, you would prefer giving that?
It can be done, definitely.
Okay,
An option can be given to the patient.
Okay.
Though we have other options as well. We will give the options and
Let's say you've done an NGS upfront, you have an exon 21 L858R, and you have probably a co-mutation as well within a RB or a P53. Would that push your decision
patients
making?
will have P53 mutation. We have done our analysis.
Yeah, great. So I mean, like, would that push your treatment management towards VEGF inhibitor as well, adding a VEGF inhibitor, be it either Bev or Ramucirumab? Let's leave that aside.
Yeah, there is an option to utilize. If we know that if P53 co-mutation is there, there is some benefit of addition of VEGF directed treatment that we know.
Fair enough. Vanitha ma'am? Yep.
No, I mean, I would put all of this as hypothesis generating. We don't have the data of, and all of the others. That TP53 is relatively common. You do an NGS, you see a TP53. We are almost in every, I mean, I won't say every, but yeah, half maybe, you said 30% in yours. So, no, it won't push me.
Okay, fair enough. But I think what we've seen across the board with all the EGFR TKs that we have, even the first, second, and the third generation TKs are, the magnitude of benefit is definitely much lesser in patients who have an exon 21 L858R, and particularly so when they have a co-mutation as well. So probably we're looking at something better than just alone in that subset of patients. It could be chemotherapy, or it could even be a combination of VEGF inhibitors. But I think probably it's time for us to start treating it slightly differently and not treat everything as the same. Yep. So I think we may not have a choice, and this is data from the Relay study again showing that the magnitude of benefit is similar in both exon 19 and 21. This is a CTONG study again showing that the magnitude of benefit was preserved even in exon 21 L858R mutation. So I probably think this is probably an idea whose time has come. This is yet another data, geftinib plus anlotinib, yet another TKI with VEGF inhibition, recently presented at ESMO Asia, again showing the similar magnitude of benefit. So I think this is probably a more pertinent question. Is it better than just a TKA alone, or is it better than TKA plus chemo? Akhil, I'll have you answer that.
Yeah. So
I know these are only cross-trial comparisons, but this is just to make sense of the data.
So I will come to the pros and cons of both the approaches. So TKI plus VEGF, yes, toxicities might be somewhat lesser. Cost of the treatment will be much higher, which is very important thing in our scenario. At least 80% patients will not be able to afford VEGF directed treatment for a long time. They can afford for some time, but they cannot afford for a long time duration. As we know, here the patients are getting for at least 16 to 18 months. If we see our own data, PEMGF carbo, yes, there are some toxicities, but the patients are able to receive the treatment for a long time, and it is applicable to our patients in a
all right, let's put it this way. If cost is not a constraint and you have a biosimilars, probably if they can go on it, would you do that? Would you think it's better?
No head-to-head comparison
Yeah,
can be considered.
Agreed. But at the end of whatever we have,
can be considered depending on the patient profile.
All right, let's get to Vanitha ma'am's view as well.
I'm confused now. NEJ 026, the OS was negative, right?
Correct.
So
there was no OS benefit.
I'm confused. So I guess the NEJ 009, the long-term survival,
Correct.
was negative. But
Correct.
At the initial
interim analysis,
it was positive. Ours was positive. We have not updated it. It appears that it might be positive, but I'm not. We haven't analyzed it officially. But I think really with NHS 026, with bevacizumab, always, it never found a place. We keep talking about it in debates, but I think in clinical practice, are you actually using bevacizumab? I'll put you on the line here. And,
thank you for that. But yeah, at least for our patients with exon 21 L858R mutation, where we have a co-mutation, we're looking at adding a VEGF inhibitor for sure. And probably depending on whether the patient can afford ramucirumab, yeah, definitely go with ramucirumab. They have a patient assistance program as well.
Do you think that is better than adding chemotherapy? Why would you add?
I'll get to that as well. So I believe that the toxicity, when you could just do a comparison between VEGF TKI plus TKI plus chemotherapy, TKI chemotherapy probably slightly more toxic than the VEGF TKI combination put together. So I think that's probably one way of looking at it. Yeah, please, you can
Do
go
we
ahead.
know that? So, I mean, because we had...
There is no head-on-head trial
so
like Akhil
we
was
had a
pointing out.
study of VEGF inhibitor, so bevacizumab and gefitinib, and it is quite a toxic regimen. I mean,
Correct.
the hypertension is unbelievable. I mean, almost every single patient I had to put on 2 or 3 antihypertensives.
Correct. But likewise, again, with chemotherapy and VEGF inhibitors as well, I mean, like probably with chemo and TKI, we know we have to count, probably looking at pemetrexed maintenance as well, continuing that for a long time. And that also has its own toxicities. We've had patients with, renal dysfunction secondary to pemetrexed and not being able to tolerate that and go off it. So I think, it can go both ways. But I think
along with toxicity, there is one more point that we need to pay attention to. That's the rationale of combination. Okay.
Absolutely.
Chemotherapy with gefitinib or erlotinib will be much more prominent inhibitor of any development of resistance pathways because it is attacking from both the sides. Okay. If you combine two different TKI, it's still the same.
No. We're not talking about TKIs alone. We're talking about blocking the VEGF pathway alone. We're talking about even
VEGF is also a
correct.
kinase
Like for
pathway,
example, anlotinib is a multi-kinase inhibitor. So we're not talking about just blocking only the VEGF pathway. If you're using a TKI, you could look at probably blocking the other pathways which the oral TKI does target. But chemotherapy, we know obviously it does have synergistic effect. I think we've had the publication from Tata as well,
exactly.
where
And
the
that's the
downstream
reason why we
signaling
got,
pathways of ERK and TRK, and all of them is being blocked as well, apart from the EGFR. So I think we're getting to that. I think that's the next part of the discussion. We're going to get into that. But I think the take home should be bad. If you look at all these scenarios, I'm sure most of us would agree that we don't treat all of them the same way. I mean, like if you had somebody with an exon 21 L861Q with brain metastasis, we don't treat them the same way. Do we? I don't think so. So I think, it's time for us probably to look at treating them differently, but how differently still remains an open question. Would you want to do VEGF TKI plus TKI or TKI plus chemotherapy? That's still up for debate. I think definitely there's no one size that fits all. There's a host of trials looking at EGFR TKIs in combination with, and this is interesting because they've looked at a third generation EGFR TKI, osimertinib plus bevacizumab. But nevertheless, this was a huge blow for osimertinib because, again, there was no benefit. The primary endpoint was not met. So, things are not all hunky-dory for the VEGF TKI, VEGF inhibitors plus TKI. So I think that's probably, I've left you at the end of it more confused than ever. But I think definitely the time is right now for us to actually start treating it differently. And this is the gefitinib plus pemcabo data, the NEG, yet another Japanese data. We definitely have an Asian flavor going today. And so this was the median PFS2, did show a benefit. Nevertheless, this was the updated overall survival. This was not statistically significant. So, I'll probably bring it again with Dr. Vanitha. I'm sure you'd have analyzed your data as well. So, again, we don't seem to be seeing an overall survival benefit with the TKI plus chemo as well. So, your take on that?
So, I don't know the answer to that. No, if I had analyzed it, you would have seen it. It would have been published, but no.
Right.
But you get a sense that we still are taking care of the same patients that we had on trial, from 5 years
So
ago.
any pointers, as in you believe that the curves are actually staying wide apart, or they're getting
hope-
closer, Vijay, as well?
I hope that they are. I think at least the world has moved on. Right? The question now is osimertinib plus chemotherapy. So I just wanted to say that I met David Blanchard recently. So he was very excitedly saying, I think Flora 2, I will be presenting at ASCO this year. So let's see. We'll find. So I think the world thinks that chemotherapy has a place in the first line setting in combination with TKI. Let's hope that that's the case.
No, fair enough. Very fair comment. I think this is the publication from Tata, where with Dr. Vanitha Manora actually had presented this at the plenary session. And we know this is probably the rationale where you're looking at inducing apoptosis, suppressing the AKT and ERK phosphorylation, which are alternate signaling pathways, and downstream signaling pathways are getting blocked as well. And look at the toxicity rates, again, 25 to 50%, definitely higher with the combination arm. Did show a benefit as far as PFS is concerned, 16 versus 8 months. So, again, let me throw it back to the presenter herself. So, ma'am, where would you look at placing this combination in your treatment armamentarium?
So
What particular patients would you like to select?
Practically speaking, I think so. We see a patient in the clinic. If that patient is affordable for osimertinib, we consider osimertinib.
Okay.
If the patient is not affordable for osimertinib, then we give them oral TKI plus chemotherapy.
Okay. So you're saying probably a poor man's osimertinib.
I think
this
so.
would probably be the
that's
poor
actually
man's
what we do.
osimertinib.
The only other comment I wanted to make about
sure.
the toxicity, it is a toxic regimen, but the type of patients that we have enrolled and the setting that we have done the study in has to be kept in mind. Now, we had a lot of 20-30% of our patients were PS2. when our patients get febrile neutropenia, diarrhea, they come to our casualty, there's no bed to admit them, we manage them as outpatients. So that has to be kept in mind when you're comparing it to the global data. You know, we
Definitely.
are certainly not...
No, I absolutely take your point on that, very rightly so. And you included patients with those rare mutations as well, not just the common mutations. But you know, what percentage actually had those rare EGFR mutation, and what percentage had those brain metastasis as well? I just wanted to know.
So,
What proportion?
20% had PS2, about
Yeah, that's
18% had brain mets. Rare mutations, maybe 5% or something like that. I can't remember.
Less than 5 had. So I think probably that's yet another unmet need as well, probably as far as, and you know, we're going to look at that discussion as well as to what you do when you have a rare mutation. Probably around 5% was the trial data looking at the rare mutations as well. And this was the FLORA2 data, as Dr. Vanitha rightly pointed out. We're all waiting for this data to be out and being presented. So, and if you look at the NCCN guidelines, and that's where I feel it's very biased, you get to see that there's no option of giving TKI plus chemotherapy. So let's not actually do this. Let's actually look at our own data and say, okay, fine, you could actually look at doing this as a viable option. Could be the poor man's osimertinib. So let's look at the TKIs that we have in the current era, and we are spoiled for choices. We have third generation TKI, but we only have access to one third generation EGFR TKI, which is osimertinib. So again, if you believe that there are too many choices, just wait until I'm done. So this is the furlong data for momelotinib, and I'm going to take you to a long list of tongue twisters. So 20 versus 11 months PFS benefit here. And again, exon 19 seemed to benefit much better. And this was the INA study, momelotinib again, yet another third generation TKI. And all of these being Chinese or Japanese molecules, I'll probably bring my panelists in on that as well. Same magnitude of benefit here. Again, exon 19 seemed to benefit more. And this is the lazertinib data, laser 301, which is also proven to be better than geftinib. So, and again, this probably is the only TKI which has shown the same magnitude of benefit in both exon 19 as well as in exon 21 L858, even in the Asian cohort. So, I'll throw it back to the panelist, Akhil. So, I know we have all these third generation EGFR TKIs, but we've never had access to it. And this starts right from the era of icotinib and ensatinib as well. We've never had access to these Chinese and Japanese molecules. Why do you think that is so? Or, are we missing the trick here?
So, why we don't have access, I don't have the answer. But
Okay.
definitely.
That probably Vijay will answer once.
But
Yeah, go ahead.
if access is available, definitely some other TKIs which are third generation and
Yep.
have shown to have very good penetrance in the brain with activity over exon 21 as well, that will be definitely
So
good.
given from the three, if you had to choose one, I know very hypothetical question, nobody has ever used any of these. Formonertinib, momelotinib,
I think
or...
formotertinib is a very similar drug to osimertinib. There might be
Okay.
one or two molecule difference only. Even
So
the
you're
dose
not-
is 80 milligram. So it might be a remake, a Chinese remake of osimertinib, which they have done officially, so
Okay.
that they have a randomized data to suggest that it is an
So
official. drug.
okay, so you don't like the lazertinib combination, huh? Because a lot of even you have first line data as well with lazertinib and amivantamab as well. All right, fine. Anyway, but I guess it's too early for us to take a call. I
In
think
fact, I was going to say that
Yeah, Vijay.
amivantamab plus lazertinib seems to be a very good data.
Yeah.
It may be toxic though. So that arm in Mariposa 2, the amivantamab lazertinib arm has been stopped though. At least they have kept it on hold.
Yeah, it's
so it
kept
may
it
be
on
there's some toxicity issues, I think.
But
No,
when-
correct. I mean,
when,
like-
when they had shown
that's-
in the first interim, the data when initially
Analysis.
came, the response rate was 100%. Man. So if the response rate is 100%, toxicity is okay.
So yeah, right. I think this is the Mariposa study that we've just been discussing. So yeah. So this is what we're looking at: amivantamab plus lazertinib, and probably we'll have to wait for this data to be rolled out before we actually start pushing for one TKI over the other. But definitely exciting times ahead. So let's go to the next subtract, which is the SINDA study. So I know we've had the presentation, and they looked at up to 5 metastases and 2 lesions per organ. And looked at giving RT along with an EGFR TKI, which in this case was only a first generation EGFR TKI, showed a PFS and an overall survival benefit as well. So, I'll just throw it back again. We'll start with you. And is it practice changing for you? Would you do this in your practice?
Surely, but the number of mets, the oligomets definition is the most important. So
Yeah,
if
fair
there's a
enough.
single met or two, we surely go with a RT.
Okay.
But with 5 mets, giving RT to 5 different sites is not a practice.
Completely agree with that. But, and also this trial did not include patients with brain metastasis. Your take on that? And we always keep talking about patients with EGFR mutation who have a high predisposition towards developing brain metastasis. And this trial the exclusion criteria, they excluded patients with brain mets.
That might be the common scenario because any patient coming with brain mets, we first send them for whole brain RT and then we start on the treatment.
Oh, do we actually do that?
If we are starting with the first generation EGFR TKIs, in that case we are surely.
Yeah, but let me say, okay, let me put this again, a hypothetical question. You have somebody with asymptomatic brain mets just picked up on imaging. Patient is completely asymptomatic. Would you just give them osimertinib, a third generation EGFR TKI, or would you push them towards getting RT?
Only osimertinib. If a patient is asymptomatic, a small lesion, no RT.
Fair enough, fair enough. So, any takers for this strategy, Akhil?
Oligometastatic disease, if lesions are close by, can be combined in one or two fields, then definitely radiation can be added to the same.
Okay.
So it's fine enough. And the study has shown some benefit of PFS.
Fair enough,
definitely.
but
It's
if
a
you
good benefit. And so it's about the location of the lesion, how big they are, what with the expected toxicity of radiation. If the lesion is bang on the colon and patient is going to have grade 3, grade 4 diarrhea for a long time, definitely will avoid that.
So I think, we're just looking at one data here, we're looking at an EGFR mutant non-small cell lung cancer, but if you look across the board, there are multiple trials which have looked at addressing the same question. None of them have been able to show a similar advantage. Probably, could that have been a reason if you had used a third generation EGFR TKI here, rather than use an upfront first-line EGFR TKI, first generation? I think those are all open questions. We don't know the answers to that, but nevertheless, I don't think this is going to be a huge game changer. We actually end up doing that in practice if you have a limited number of oligometastatic disease. But then again, the problem comes with the definition of oligometastatic versus low-volume disease, and that's going to be a never-ending debate. So I think, these were probably the questions. There was an imbalance between the mutations, second-line treatment, and less than 5 months brain mets were not included. And so, I think those are probably how we got to look at interpreting that data. And let's move on to the next, which is the atypical EGFR mutations. When we talk about EGFR, again, we think the uncommon mutations are probably very groovy mutations. What is the role of IO drugs in somebody who's got an EGFR mutation or EGFR mutated non-small cell lung cancer? Do we actually believe that, there is a role? Because you just saw the data being presented for sintilimab plus anlotinib. So Akhil, we'll start with you. And this is what we've known already. And this is what we all think it should be, because, immunotherapy, you cannot keep immunotherapy out of it. And, we've had the subgroup analysis from the IMPAR 150, only about 10% who had an EGFR mutation did show a benefit. And, the addition of bevacizumab did seem to be, I know probably I'm making a pitch here. Sounds like I'm making a pitch for a VEGF inhibitor. But, you can look at the data there. That's just there for all of us to see. And you can see that the curves are actually staying wide apart when you give a VEGF inhibitor, which is bevacizumab. So anyway, your thoughts, Akhil?
So it's
at least in the uncommon or atypical, they're calling it the chemo-free regimen, sintilimab plus anlotinib.
So definitely no for the standard mutations, but uncommon mutations.
Yeah.
If you are unable to utilize more selective drugs, for example, mobocertinib or amivantamab, these are the specific for exon 20, which is feasible. If that are not feasible,
let's say non-exon 20 insertion, but atypical EGFR mutation would be your choice. Would you look at using this regimen?
Still not so sure about utilizing in the first line.
Okay, fair enough.
Yeah.
Yep.
Further data needed in this field.
So, okay. Dr. Pratik? Yeah, ma'am, please.
What is the logic of this arm? Do you understand this? Or?
Exactly. That's exactly what I wanted to ask as well. So, is there any we've always talked about, fundamental question being if somebody's got a driver mutation, look at targeting the driver mutation. This seems to go away from that. You're talking about not targeting the driver mutation, given that you have, like we pointed out, even drugs that can work in atypical EGFR mutations like afatinib, why would you want to use this regimen at all, was my question as well. So, no, Pratik. Yeah.
So, to my understanding, less than 5% of the EGFR positive patients have signatures which are suitable for immunotherapy. So, if we can use those signatures and pre-select the patient, then yes, it has some relevance. But otherwise, for majority of the EGFR mutated patients, immunotherapy wouldn't be.
So, the hypothesis actually is that they're making a cold tumor hot. Yeah. By actually, making the tumor and microenvironment more conducive to immune checkpoint inhibitors by adding a VEGF inhibitor. So is that something that we're going to buy into?
Yeah, so unless we opt for such a combinatorial therapy, wherein, again, the chemotherapy combination can be really helpful, because chemotherapy is also inducer for, immunotherapy response. So that combination can be very well considered.
Yeah, fair enough. I think, that's something, that's always been a hypothesis. We still don't have the data for that as of yet. So I think, like we've all discussed, exon 20 insertion, we're spoiled for choices. We have a huge host of drugs already approved are amivantamab and mobocertinib. But remember, not in the first line. They have not yet approved currently in the first line. They're only post-progression on a platinum that you can actually use these drugs. And we have a host of other drugs like sunvosertinib. Also, we have the phase 3 data, currently not yet approved though. And can you use them in the first line? Ongoing trials looking at the Papillon, the XCLIMB2. We'll have to wait for that data before we actually look at using it in the first line setting. So resistance mechanisms, and this will probably be the last abstract that we're going to discuss. So, yeah, please.
So if Papillon ends and XCLIMB ends and both are positive. Now Papillon has amivantamab and chemotherapy. The other one is only
mobocertinib.
oral TKI.
Yeah.
So then where would you place it? Because
No,
they're not comparing to each other.
Correct. Absolutely right. So if you ask me, I would definitely look at doing only mobocertinib upfront, and when they progress, probably look at doing amivantamab plus chemotherapy. That would be how I would look at doing it. Vijay, your thoughts? You've been part of that as well, so.
I like amivantamab a lot. So my
You're a
choice
huge
will be
amivantamab fan, so you're going to go upfront with that. Mobocertinib?
They took a risk by giving it alone because the
true.
response rate was not great in the.
Very true. But probably we'll have to wait for the final trial. Final trial results to be out and to be rolled out. But moving on to the resistance mechanisms, we know that if you start off with the first generation EGFR TKI, you're likely to have a T790M mutation in about 50 to 60%. But probably, if you start off with a third generation EGFR TKI, then you're likely to have a more diverse resistance mechanism, which could be a downstream signaling pathways like MET, RAS, RAF, MEK, ERK, BRAF, PIK3 mutations. All of them come into the picture. So I think this is probably the gold standard where we're looking at osimertinib, versus chemotherapy, especially in patients who have a T790M. So that definitely is gold standard. So let's look at the contenders. This was the oritinib data, especially in patients who have a T790M. So is this a contender? And I'll throw it back to Akhil. Do you believe that this is a contender? In the second line setting, somebody with a T790M mutation, do you think osimertinib is unchallenged in that setting, or do you think we have contenders to the throne?
There is definitely, it seems to be an option, but there will not be any head-on comparison, we know for
Absolutely.
sure. So that is not going to come.
And
so
this is only phase 2 data as well.
Yes, and also the access to the drug and the cost, these remain very important for us. Whatever we may discuss, if we don't have access, if we cannot afford, that's out of question.
Probably, yeah. And probably, just to highlight on, we actually have a drug that's been proven, we have a head-on-head comparison actually with osimertinib, and that's something that I really wanted to show here. Abivertinib, that's yet another third generation EGFR TKI, proven to be better than Tegriso or osimertinib in patients who have a T790M mutation. So for the first time, we are actually getting to see TKIs go up against each other. So I guess it's only a matter of time before we actually get to see this sort of data as well. So probably we have a winner, and this is the amivantamab plus lazertinib data, especially in patients who have progressed post osimertinib and platinum-based chemotherapy. The tumor response rates, you could say around 30%. Probably, and I think probably that's going to be the real deal. I'm sure Vijay would agree that you're a huge fan of amivantamab, Vijay. So and patritumab deruxtecan, where do you think, if at all, because this data also seems to be pretty impressive, and there's a host of trials looking at addressing this question of HER3, because it's probably the only drug which is targeting HER3 right now. We don't have drugs that can actually capable of working on HER3. So, with that, probably we've come to the end of our panel discussion, and I'd like to thank my panelists for Yeah, correct. It was not correct. Mechanism. No, it was definitely not. They didn't look at only taking patients who had a HER3, but that's one drug, or probably rather I should say the only drug which acts particularly or specifically targeting the HER3 alone. So it's an antibody drug conjugate directed against HER3. So I think probably that is a very interesting option, especially in patients who have progressed on a first generation TKI or even a third generation TKI for that matter. So with that, I'm going to say thank you all. Thank you to my panelists and for the audience as well for being so interactive. Thank you so much for that. Thank you.
Thank you, sir. Now may I request Dr. Akhil Kapoor to moderate a session on case-based panel discussion in EGFR mutated non-small cell lung cancer. The panel members include Dr. Ajay Kumar Singh, Dr. Nilesh Damne, Dr. Rakesh Piniti, Dr. Samir Shirangwar, and Dr. Jacob George, and Dr. Dilip V.
So thank you to the esteemed panelists and the organizing team. So now we are going to discuss, after the discussion on choices of the treatment, we are going to have some discussion on some special scenarios in EGFR mutated lung cancer. So there will be 3 scenarios which we'll be discussing. One is EGFR mutated with high PD-L1, another is oligoprogression, and a patient with brain mets. So this is the usual case scenario which we see. Sometimes what happens, PD-L1 report comes very fast, PD-L1 report is available, and we sometimes see that the patient has been started on immunotherapy from outside institute. So Dr. Samir, do you see such situation when PD-L1 has been very high and without waiting for EGFR, somebody had started on immunotherapy to the patient? How have you seen such scenario in your practice anytime?
Not seen such patient, means already started on immunotherapy and then the EGFR coming positive. But if such patient is there, definitely the immunotherapy is out. Target therapy should be the way to go.
So we have learned this from our experiences from the last 2 to 3 years, that definitely if PD-L1 is high, but still you need to wait for the EGFR report at least. So I think everybody will agree. Ajay?
Yes, sir. Usually we wait for the EGFR before starting the immunotherapy.
Okay. At the same time, we know that RT-PCR has its own limitations. It is not sensitive enough sometimes, and patient has high PD-L1. So do you think is it right to wait for NGS as well for getting so that we can confirm, say EGFR was negative or positive, or EGFR uncommon mutation? Anything to suggest?
After RT-PCR or direct upfront NGS?
At the baseline, firstly.
If we, at the baseline we have RT-PCR negative and high PD-L1 and
so basically we use RT-PCR. Even if we are sending NGS, we usually don't wait for it to start.
Except it's an unusual scenario where I see there is a young patient, 30 years, and female, and having aggressive disease like extensive metastasis, where I highly suspect it must be some driver mutation. Otherwise, except all these conditions, I'll consider starting immunotherapy. Maybe we'll do the NGS because now we see NGS are detecting more and more mutations.
Mutations, correct. Even uncommon mutations.
Except for these patients where I suspect there will be driver mutations, in all other situations I'll consider starting immunotherapy.
Yeah. So definitely in our practice, yes, please. Less chances, yes. So definitely in this scenario, we need to consider many things. If RT-PCR, we found that tissue was, pathologist commented that tissue was just adequate and RT-PCR is negative. Definitely for getting an NGS, we need more tissue. I think we should go ahead with taking more tissue. At the same time, we'll need to start treatment if the patient is symptomatic. So I wanted to bring out that point, which has highlighted by Dr. Pratik already, that if tumor tissue is inadequate, your tests will not be accurate. So keep that in mind while taking decision. If patient is symptomatic, you need to start on chemotherapy, but whether you will add immunotherapy based on PD-L1, it needs to be dependent on many things. Ajay has highlighted one situation where you are suspecting a driven tumor, molecularly driven tumor, but you didn't find any, and you had to start treatment. So in that scenario, there is an option to start chemotherapy alone if patient is symptomatic, and get a better tissue and get a NGS if feasible. Any?
Okay. Rather than getting a better tissue, why not do both liquid biopsy and tissue?
Yes. If liquid biopsy,
I think that is the best way to go.
So let's take comment. Any suggestion on use of liquid biopsy? How common is it in your practice as well?
Maybe combination of both.
Okay.
Getting NGS on both.
So many, it's like who practice exclusively lung prefer we should do both solid as well as liquid, and we may gain 5 to 10% extra. But in real practice, I don't prefer. We'll do only FFP sample. If it is inadequate, then we may confirm liquid biopsy. But both is definitely not financially viable.
Yeah. If we have coupons that we can get.
So yes, wherever feasible, by any method, definitely utilizing a combination might be a good option. but usually not very common in our routine practice. That is what I can say. Rakesh, do you agree?
I think before starting, apart from driver mutation, before starting immunotherapy, I would like to see the NGS report as well, because there could be markers of resistance, there could be markers of basically progressive disease, MD1 mutation, or could be other driver mutations, TP53 or KRAS mutations. This could actually give us or empower us to use immunotherapy or demotivate us to use immunotherapy. So NGS report, apart from the PD-L1 report as well, has a lot of implications starting immunotherapy. So I will wait for that.
So point well taken. NGS definitely adds to our some information whether immunotherapy is going to be having a good effect or not. There might be some additional information, but it might not be the case always. But yes, it might give some additional hints. So moving further ahead,
12 days?
10 to 12 days, man. We are outsourcing most of the times. We have some in-house capabilities as well. So if we are trying in-house capabilities, we are more concerned about the tumor proportion in the biopsy specimen. And if all those checks and markers are actually adequate, we probably go in-house. In-house, we get it around 6 to 7 days, man.
So turnaround time is highly variable throughout the country. That is what I can say.
Excuse me.
So 5 days only PDL1 ALK by IHC, I would say. Rest everything will take at least 10 days, 8 to 10 days.
10 to 10.
The setting where I practice is not like this, unfortunately. So a lot of times it's just by PCR. Patients who can afford this immunotherapy wouldn't arise, so there's not an issue. If patient is sick, I start and then I go by whatever RT-PCR I get. Otherwise, I can wait for the NGS if they're affordable for NGS as well as immunotherapy.
Yeah.
But we don't have in-house NGS, so it makes it difficult for me.
Okay. So it seems that turnaround time is highly variable throughout the country. We expect around 3 to 4 weeks at least in our setting, but I completely agree there in some settings it might be some significantly faster. We always try to strive for the same, but it is not
It's
feasible.
always a difficult thing, ma'am, because it is not validated most of the times. So we are doing it as a run for few patients, and we are doing it only for selected where we actually expect a mutation to happen. So it's always a tricky business. If we have no mutation and then we are again fixed, are we right, or we are going to repeat it again elsewhere, something like that.
Okay. Also, we are getting, even when we are getting NGS from outside labs, some labs are offering it within 10 to 12 days. So I completely agree. Small panels at least, they are reported in somewhat shorter time. So that remains a problem, and that depends on your practice and situation. And if patient is highly symptomatic, PD-L1 is high, but other reports are awaited. Dilip, how do you treat that patient?
So if a patient is symptomatic, I would start him on chemotherapy alone. I will not.
You'll not add immunotherapy.
Not add immunotherapy.
So if patient is asking why not to start immunotherapy, how will you explain to the patient?
So basically, I will tell. We'll have to explain we'll have to wait for the other molecular tests to start on immunotherapy, which might indicate a resistance to immunotherapy.
Definitely.
Or less benefit for immunotherapy.
Yes. At the same time can be harmful as well if mutation is positive. Yes, Ajay?
Does adding immunotherapy from cycle 1 will give you extra benefit?
No, not necessarily.
From second
Yes.
cycle.
So in that same, that is what we do in our practice as well. If patient is very symptomatic, you start with chemotherapy and see the other reports and recording. But there are many trials now ongoing at our center, at many close by centers. That is why it is always, if patient is not symptomatic, definitely we can wait so that patient can be a part of any inclusion criteria of one of the trials. Because if sometimes we see that most of the trials have strict inclusion criteria, if patient has been started on chemotherapy, then patient will not be fit enough for the trial. So that is why we need to expedite the NGS reports as much as possible. That is an important thing. So let's coming to outcomes of osimertinib. Osimertinib outcomes, is there any relation to PD-L1 status? Anybody would like to comment on the same? PD-L1 low versus PD-L1 high, because we see that EGFR mutated patients tend to have a high PD-L1 expression. is that makes any difference in the outcomes? Ajay, what do you think?
So, no, not really, sir. I have seen in the practice.
Yes, yes. And even the data from the flora suggested the same. You can see on the dice on the screen, PD-L1 more than 1, less than 1, or unknown. All patients seem to have similar quantum of benefit as well. So PD-L1 doesn't change the outcomes with osimertinib, that is for sure. So coming further ahead, coming to next question which we had on discussion about oligoprogression. So this is a 45-year lady with exon 19 deletion, was on osimertinib from close to 18 to 20 months, now having 2 metastatic bone lesions. Sir, how do you treat that patient? Patient has 2 new bony lesions on osimertinib after 18 months.
So this I'm having it in practice frequently. Oligoprogression generally, I proceed with radiation and continue the osimertinib and active surveillance to see how it is going.
Yeah, this is perfectly fine. This is also what we usually practice. Any difference in opinion?
So in addition, we try to find out the resistance mechanism.
Yes,
if
yes.
tissue is available, we'll try to, obviously it's a bone so difficult to do, but at least we'll counsel the patient for do a liquid biopsy to
liquid
see.
biopsy you will prefer in such scenario. So it is very important to identify the mechanism of resistance on which the patient is progressing, because that will help in deciding the next line of treatment. If the bone lesions, as sir suggested, it can be targeted by radiation. At the same time, you're continuing osimertinib. But if you get another targetable mutation, you might be very happy. So Dr. Samir, any points?
Akhil, rather than mutations are always important, but other than that, disease biology is also very important. So I had one patient. He was all molecular test negative. Started on treatment in around 2017 with PEM carbo, and he did very well on PEM carbo. Almost received 50 cycles of maintenance pemetrexate. Then he had only single adrenal nodule, which was oligoprogression. We treated with the SBRT. Now he has completed almost 75 cycles. He's in complete remission.
Yes, we see.
He was driver mutation negative. So always, if the patient disease is like responding very well for a long period of time, just having a small one-side progression.
I completely agree. So in oligoprogression, whether driver mutation positive or negative, we try to treat the oligoprogressive site with local ablative treatment and continue the treatment otherwise. So, Dr. Dilip, if you find a targetable mutation when the patient has oligoprogressed on osimertinib, for example, if you get a MET amplification, what will you do in that scenario?
That scenario, if the MET inhibitor is available as a clinical trial or in this thing basis, and if the patient is agreeing to take the MET inhibitor, then I would consider that.
Okay. Anybody would like to combine osimertinib with MET inhibitor? Anybody is having experience of the same?
Sir, if you repeat, NGS is showing there is a persistence of the baseline EGFR 19 or 21 along with the new MET. So definitely the recommendation is to give combination of MET plus EGFR targeted.
So rather than MET, I have a patient of ALK mutation being positive. So again, one patient started on 2018, and after 2.5 years, he did well for osimertinib, then chemo, then had a progression. That time I did a biopsy, it was ALK positive.
Okay.
So I did a liquid biopsy, it was EGFR positive. So I treated with alectinib and gefitinib. Now he is again in CMR almost 18 months.
Okay. So here I will take a comment from Vanita ma'am. We have our published literature on EGFR plus ALK combination. Ma'am, your comment, if you get sometimes ALK on progression.
Yeah, no, ALK is a known, one of the known resistance mutations, and I think not just ALK but MET or anything, and regardless of whether the EGFR is persistent or not, at least the current thought process is to continue the EGFR inhibition. Patient had an EGFR driver to start with, so you continue. So most of the trials also you'll see the savolitinib plus osimertinib or capmatinib or whatever, they do continue the EGFR inhibitor. So in your patient, you also had the EGFR plus alectinib, right?
Actually, ma'am, the tissue biopsy showed a ALK positive report, and there was no EGFR mutation. But liquid biopsy picked up the EGFR mutation.
Okay.
So
you treated with both the things.
I did both because I saw literature. So there were only few case reports, and there were few case reports of combination. So I thought I will just get a liquid biopsy also. So it picked up the EGFR mutation. It was the same which was previously reported.
In such a case, if brigatinib is available,
brigatinib is
brigatinib is available, always available, just not to our patients. It's very expensive, so you can.
Compassionate access program, Ajay, or anybody having experience of compassionate access?
Brigatinib till now I not
They are
seen.
not giving, compassionate. No compassion.
Okay. So we depend on a lot of drugs for compassionate basis and we utilize
I
this.
have a question. How many times it has happened that you kept the patient who is asymptomatic progression, oligomeds, given radiation, and 2 months back the patient has come in PS2, PS3?
So sir is asking about the scenario when we tried to continue on the same treatment, added local radiation ablative therapy, and how the patient deteriorated and rapidly. Any comment?
Not so far, but if they deteriorate rapidly, I would want to see if there is small cell, transformation or something. I've not had that so far.
So probably the tumor has changed into aggressive histology, so may not have responded to radiation and it took its natural course. That's why the patient landed with aggressive. So repeat imaging may show multiple sites of involvement. May not be the radiation induced, it's the disease which has caused the performance status down.
So the reason why I'm telling you is that we have this experience both from the Geftinib versus Pemetrexed randomized study and Geftinib versus Geftinib carboplatin. Patients who had oligoprogression and we were seeing that they were symptomatic, we continued the same treatment give. We couldn't give treatment in 30% of the patients at progression. And the reason, one of the prominent reason was that asymptomatic progression, we continue the same treatment. So even though literature says that in both of those papers discussion, we have put a caution that such patients, asymptomatic progressions, we are giving local therapy. It's better that you have closer follow-ups of this patient because at least, I think 20%, madam, we couldn't give further treatment until they actually came in stretcher like or PS3 condition.
So what would be the definition of oligometastatic disease, sir? Like oligoprogressive disease, sorry.
So the definition was, we didn't have any protocol defined definition. What we had did at that time was there were 3 meds or 4 meds. We used to send it in MDT. They used to say, okay, the symptomatic, give radiation, and we continue that. So it was always an MDT decision. It was not even a decision at the level of one consultant. But in fact, we burnt our finger in Geftinib versus Pemcarbo. In fact, if there's someone who was a part of the data entry, he would have told, we were surprised. We wondered that we would be in, when we were analyzing the data of Geftinib versus Pemetrexed carboplatin, we were sure that we are going to get an OS benefit. And we saw that there was a good benefit in terms of PFS, but the OS actually was reverse. It was actually reverse. The OS for Pemetrexed carboplatin was higher than the OS for the Geftinib arm. And that was because 94% of patients on the Pemetrexed carboplatin arm were shifted to Geftinib. Because the physicians were very trigger sensitive. Oh, Pem carbo mein progression hua, chalu kar do. But the other way around, it didn't happen. We had the same experience in Geftinib versus Geftinib plus chemotherapy also. That in that, so the thing was, what I just wanted to say is that even if you see the FLORA data also, not all progressions have received the second line treatment. If you looked at a supplementary appendix, in FLORA also 70% of the patients only received second line treatment, which means that this is a phenomena which we should be very careful with, that because I agree, all guidelines would say asymptomatic progression, continue and use. But I think there should be a word of caution here that when we continue, we also monitor them very closely because these patients can actually come in poor performance status.
So again, a 2-side, 3-side and 1-side progression, they may behave differently.
Still, definitely if we are, because the oligoprogression and this definition is highly variable actually, so it might depend. So when we are analyzing ourselves, we'll know that this patient will not be doing very good. We already understand that because of the nature of distribution of mets. If it is simply 2 bone metastases which are close by, can be encompassed in the radiation field, and you are also able to do at least liquid NGS so that you can get access to a next treatment. If you are getting any targetable mutation, you can add to it. Definitely that will be much better.
So again, sir, I think after the progression, the remaining treatment lines are also important. If suppose already we have given, we know there is no good option, which is better to continue. Means we know patient will hamper, but obviously if you are given Gefitinib and we know there is a 790M mutation and we know that there is a good option. So instead of even there is a oligoprogression, I know this osimertinib will work well and there is a progression in vein. So obviously I will prefer to use osimertinib.
So if we get we were on the first line or second line treatment, such a generation drug, if it is feasible to utilize next generation of treatment in presence of T790M mutation, definitely that will be much better. I completely
That
agree.
is also means what the treatment
But
we
here,
are having for
in
that.
this scenario, we were discussing about osimertinib with oligoprogression. So that is a different ball game. So I completely agree with your comment in the real practice. If we are continuing, if we are doing NGS on osimertinib progression, this is what the data is suggesting, which I wanted to show here. T790M mutation was preserved in 20. So this is a scenario when the drug was only approved for T790M mutation. This is that data. And out of 118 patients, 42 had molecular profiling done at progression. And T790 was preserved in 50% patient. It was lost in 50% patients. And where T790M mutation was lost, there were higher chances of having C79S and L792 mutations. So that is another one point. This C79S and 792, these two are important mutations, especially in the scenario when T790M is lost. So in those cases, we don't have any drug till now. Fourth generation drugs are expected to work on these mutations.
Akhil,
Another option.
Sorry to interrupt you.
Yeah.
I mean, like C797S mutation, I mean, when you talked about it, do you look at the cis or the trans mutation?
Yes, that is very important. Cis versus trans, that we do discuss in our molecular tumor board, get the inputs from our molecular team. And I was just going to discuss about, yes, cis T790M mutation with T790M mutated patient with C790S cis type. There is a retrospective study of 5 patients only, where they have combined brigatinib with cetuximab, and it had resulted in the partial response rates of 3 patients, and 2 patients also had stable disease with PFS of around 12 months. So that is one important thing. But apart from that, yes, 4th generation TKI is what we are looking forward for the same. That will be the best way to treat them. That is what I think. Any comment on the same?
Like you rightly said, cis mutations, probably they're more susceptible to your first generation EGFR TKIs as well, so you could re-challenge them. Trans, you look at adding VEGF inhibition. So I think that's probably one of those take-homes as well. Yeah. We'll probably have to go back to our molecular oncologists and ask them and grind that information out of them. Because
yes.
Yeah, definitely. Yeah, definitely. It never is.
So far, never got the C797.
Okay. So moving further ahead, definitely if multiple lesions, we are going to change the treatment in form of the other formats, but oligoprogression, we need to consider the therapies which are feasible. Now coming to CNS metastasis scenario, a patient who was on chemotherapy, adjuvant chemotherapy for a stage 3A disease, the patient was found to have progression with multiple brain metastasis, and osimertinib was started in this patient because the patient was found to have EGFR exon 19. When OC was started, around 5 days later, the patient had increase in ataxia. How to manage that, and what is the usual practice in this scenario? Anybody would like to take that?
It was because of brain metastasis?
Yeah, patient was on adjuvant treatment for stage 3A disease. A patient had progression, exon 19 was detected. Patient was started on osimertinib. On the day 7 of osimertinib, the patient was having increase in ataxia.
MRI brain was done, it was metastasis.
Yes.
It's only 7 days.
Yes, only 7 days.
Maybe just give steroids and see, wait, if there is no response, then we can give radiotherapy.
Yeah.
I think they should respond.
Yeah, that is what usually happens. Initial level, ataxia and other symptoms might be present, but you need to tide over that situation with the utilization of steroids in sufficient doses.
Just
and
one
then
comment here. This is in fact inferior Vermean lesion, so this will be a posterior fossa lesion. So we should be very careful keeping a posterior fossa lesion
On
who is having
observation.
edema on observation,
Yes.
and more careful not to give radiation in this situation. Radiation at this side, initially there would be edema, and you will be predisposing patient for a
higher chances of
herniation.
tonsillar
So this
herniation.
is for supratentorial, perfect. It would respond, but be careful for a posterior fossa lesion before taking that decision of keeping him only on osimertinib.
So, sir, what your approach in this case?
So in such cases, we would get this for the brain mets clinic, and if it is a lesion which has lot of edema around, I would actually ask my neurosurgeon to go and remove it.
Okay.
Yeah, madam, most of the time they agree. Initially, they never used to agree because they used to thought that every lung cancer is to die. Now they also know about EGFR mutations. So they agree nowadays.
So in this case, actually, yes, the patient was planned for craniotomy as suggested by sir as well, and this was the preferred way to manage. Though it might not be feasible always, but yes, it is a preferred option in this scenario. That is what needs to be highlighted. In this scenario, again, the patient had a significant decrease in the lesion after careful utilization of the steroids, and the lesion responded very well. And
Sir, even after the response and improvement in symptomatic, still he underwent surgery.
no, the patient underwent surgery, immediate surgery because of the increase in symptoms, and for the first 2 days of steroid, the patient did not have much responses. That is why the patient underwent a resection. So, because the patient might be non-salvageable if we delay further. So, you need to select the patient wisely. Patient responded or not responded to steroids. This is just a graph to show that yes, osimertinib penetrates in brain well, and you need to utilize accordingly. Now, due to shortage of the time, I will just skip and say leptomeningeal disease and spinal metastasis. Osimertinib is the preferred drug. Sometimes we utilize osimertinib 160 milligram. That is the preferred choice most of the time which we see, but might not be always feasible based on the cost. In such cases, we also utilize intrathecal methotrexate. So, Vijay sir, in brain mets clinic, Vijay sir, in brain mets clinic, a patient has been found to have leptomeningeal disease and CSF is positive. Osimertinib 160 milligram is not feasible. 180 milligram patient is affording. Would you add intrathecal methotrexate?
So there is a phase 3 randomized study going on at present. We are doing it for third generation TKI, third generation TKI alone, third generation with ITMTX. So the patient would preferably go on that study.
Under the study. Okay. Any comments, ma'am? For yeah.
If a patient is like CGHS or any, they will give, I don't know.
160 milligram we have utilized, but not in some specific group, I cannot say. Thank you. I think we'll end here. Thank you everyone.